Hello, hello. Can you guys hear me? Hello.
Hello. Yes.
Oh, okay. So today we are going to discuss mainly the lower limb anatomy. So first of all, we are going to discuss nerve plexus. That is lumbosacral plexus, right? We are going to discuss lumbosacral plexus. As you guys know, what is plexus? Whenever you have a network of nerves that is coming out of your spinal cord, it's basically known as plexus, right? And as the name indicates, we are going to discuss lumbosacral plexus. So those network of nerves which are coming out from the lumbar and the sacral region of your spinal cord are known as lumbosacral plexus, right? So here you guys can see this is your lumbar region here, and these plexus or network of nerves coming out from the lumbar region are known as lumbar plexus, and those coming from the sacral region are basically known as your sacral plexus. So here you can see your lumbar plexus. So basically, the lumbar plexus is formed from the T12 to L5, right? Here in this picture, you guys can see these are your lumbar plexus and these are your sacral plexus, right? So these are your lumbar plexus, which arises from the lumbar uh, L1, L2, sacral. Right, we'll be now discussing the individual nerves. What are the function of those nerves? Right. So the first nerve which come out of your lumbar plexus, which we'll be discussing, is your iliohypogastric nerve. Right. Okay, iliohypogastric nerve. Here. Okay, these are your sacral plexus, and here you have your lumbar plexus. Right. So the first nerve which come out from your branches of T12 and L1. Here you guys can see this is your iliohypogastric nerve, and we'll be discussing it. So can you guys tell me that what's the function of iliohypogastric nerve? Yes. Hello.
Hello.
Yes.
Yeah, iliohypogastric nerve is a motor supply to the internal oblique and transversus abdominis.
Perfect. So it have motor and sensory innervations. So the motor innervation, it basically supplies to the transverse abdominis, this muscle, and your internal oblique. You also
Mhm.
have a sensory supply of iliohypogastric nerve. As the
Yeah.
name indicates, it's going to supply the hypogastrium. And you guys know what's the hypogastrium? It's just the region below your umbilical cord and above your pubic bone. This region, it's your hypogastric. So it's going to give the sensory supply to your hypogastric region, right?
Yes.
Okay, so how is this nerve damage? It's normal. For example, if a person is having some abdominal procedures, for example, laparoscopy, right? So basically, we are going to insert like the trocars here, three trocars, right? And then we are going to have a transverse cut to this area in which we'll be inserting the camera, if you guys know, right? And then we'll be removing the gallbladder, right? Okay, laparoscopic surgery. First of all, we are going to insert the gas inside your abdomen in order to distend it. So it can also cause gas emboli, if you guys remember, right? So in this procedure, for example, if we have a cut to this area, so it is more likely to damage the nerve that is supplying the hypogastrium. And what's the name of that? Iliohypogastric nerve, right? So what would be the symptoms if you damage this? You are going to have like sensory loss. You are going to see burning sensation, paresthesia, and tingling in this suprapubic area. Okay, that is the hypogastrium, right? So the second nerve which we'll be discussing is genitofemoral nerve. Here you guys can see. Okay, let me just our plexus. Okay, so genitofemoral nerve. So you guys can see the genitofemoral nerve basically arises from the L1 lumbar and L2 lumbar. Here you can see it forms the genitofemoral. So as the name indicates, genitofemoral. So can you guys tell me it's going to supply which parts? It is genital. Hello, hello.
Hello.
Okay, just give me a second. Hello, can you guys hear me?
Yes, we can, doctor.
Okay, so the second nerve which we'll be discussing is genitofemoral nerve, right? So as the name indicates, can you guys tell me it's going to supply which areas? Genito and femoral. The name already tell you. Hello.
Genital region and the thigh.
Okay. Okay. Can you repeat it again? It's going to supply your.
So your scrotum and your
Okay.
medial thighs.
Okay. So basically, you have motor and sensory supply. So motor supply, basically, you have a cremasteric muscle that is basically surrounding your scrotum, right? And we have a reflex that is also known as cremasteric reflex. What's cremasteric reflex? For example, if I'm stroking the inner thigh, so what happens? The ipsilateral side of your scrotum will rise, right? That is basically known as your cremasteric reflex. So the the cremasteric muscle is basically supplied by genitofemoral nerve. It's a motor innervation. You also have sensory innervation, and it basically supplies sensory innervation to the skin of your scrotum, and like in male, okay, in male, but in female, it's going to supply the labia majora and skin over mons pubis, right? Okay, so this is the genital portion of this nerve, and as the name indicate, femoral nerve. So it's going to supply the femoral part. This is the femoral part. That is the upper thigh, right? It's going to supply sensory innervation to the femoral or upper anterior thigh, right? So, okay, how the genitofemoral nerve is damaged? Basically, for example, if you have a surgery, let's suppose any surgical procedure going on in the abdomen, and you have a retractor blade, if you guys remember, there are blades like that, okay, in which we just place those blades and we just pull the skin apart, right? So these retractor blade, often whenever used in abdominal surgical procedure, it can damage your genitofemoral nerve, because it's also going to supply the anterior thigh, right? So if we are damaging the genitofemoral nerve, it means you are going to see loss of your cremasteric reflex in male, and secondly, you are going to see decreased sensation on anterior thigh, right? And what are some of the common causes in which your genitofemoral nerve get damaged? Yes, it's abdominal surgery in which we are using retractor blades, right?
Mm-hmm.
Okay. So now let's discuss lateral femoral cutaneous nerve, as the name indicates. Okay, just let's come here. So we have already discussed iliohypogastric. We have already discussed the genitofemoral. Now let's discuss lateral femoral cutaneous. As the name indicates, cutaneous. It means it's purely sensory. It is going to supply sensory supply, right? To the lateral thigh, lateral femoral, femoral, the femur bone, right? So it's going to
Mm-hmm.
supply. Okay, it's cutaneous would indicate that it's purely sensory. Lateral, it's going to supply the lateral femur, and it arises basically from your L2 to
L3.
S3 here. Okay, L3. L2 and L3. It's going to form lateral femoral cutaneous nerve. So, as we have already discussed, it's going to supply your lateral femoral thigh, but it's going to run somewhere here in the inguinal ligament, right here. So here is going to supply the lateral portion. So, in which condition are we going to see damage of lateral femoral cutaneous nerve? Yes.
Tight clothing.
Okay. Yes.
Obesity.
Perfect. Tight clothing, it can compress upon this nerve. Obesity, yes, for example, if a person is obese, right, with big belly, so it's also going to compress these areas, right? So you can have damage to the lateral femoral cutaneous nerve, right? And once our lateral femoral cutaneous nerve is damaged, basically that is known as meralgia paresthetica. What does the meralgia paresthetica means? That you will be having a burning sensation, paresthesia, or diminished sensation on the lateral thigh. Simple, on the outer lateral thigh. As we know, that is going to supply your outer and lateral thigh. So this is the function of lateral femoral cutaneous nerve. Okay. So now let's discuss another nerve, that is obturator nerve, right? So can you guys tell me that obturator nerve is going to supply which muscles? Yes.
Adductors, adductors.
Yes, it's going to supply all of the adductors, right? So
Mhm.
basically in the thigh you have adductor. What's adductor? You are adding the thigh to your body. Okay, like that. Pulling the thigh towards the body. So what are some of your adductor? You have adductor longus, adductor brevis, adductor magnus, right? So basically
Mhm.
they are present on the medial side. So they, whenever they are like stimulated, these muscles, so they are going to adduct your thigh, right? So
Mhm.
obturator nerve is basically going to supply those adductor, right? And it's also going to supply some of the sensory innervation to the medial thigh, like a little area inside the medial thigh. Okay, the obturator, like most of the sensory supply to your thigh is like anterior and medial is basically by your femoral nerve, right? But you have a little area which is basically on the medial side, which is basically supplied by your obturator nerve, right? Okay. So for example, if your obturator nerve is damaged, so what happens? The patient would be like, it would be difficult to adduct his thigh, right? The patient's thigh. Secondly, you will be seeing some sensory deficit at this region, the small region which the obturator nerve is supplying, right? So here, as you guys can see, okay, this is your obturator nerve. Okay, basically your obturator nerve is here, right? So it can damage in certain pelvic procedures. For example, if you are having certain pelvic procedure and we have an instrument that is known as trocar. Can you guys tell me what is trocar? Like in laparoscopy, we also use a trocar. Like it's a hollow tube which we insert inside the abdomen, and then we can have different things passing through that tube, and we can just undergo the surgery. Like for example, if you are inserting the camera into this tube, or for example, we are cutting the mm, let's suppose a bladder. So basically, whenever we are having pelvic surgeries and we are inserting this trocar, so it's very likely to damage the obturator nerve with this trocar, right? Okay. So can you guys give me the overview of the three nerves which we have discussed? Yes.
Yeah. So the first one that we discussed with is your
I
iliohypogastric nerve.
perfect.
Yeah, so
Okay.
the iliohypogastric has both motor and sensory functions. The
Okay.
motor supply is it will give motor supply to the internal obliques and your transversus abdominis.
Okay. Perfect.
And the sensory supply is to the hypogastric region, that is like below the umbilicus and the suprapubic area. In between that area, it will give sensory supply.
Yes.
And this nerve will be most commonly injured during any abdominal surgical procedures
Yes.
like laparotomy, laparoscopic surgery.
Yes. Okay.
Mm.
Then secondly, we discussed
Second is your genitofemoral nerve.
genitofemoral. Yes.
So genitofemoral nerve, this is also like motor and sensory. So motor
Okay.
supply, it will give to the cremastric muscles, the skin lying the scrotum, and
Okay.
the sensory supply. So the genital branch of the genitofemoral, in the males, it will give sensory supply to the scrotum, and in the
Okay.
females, it will give sensory supply to the mons pubis and the labia majora portion.
Perfect.
And the femoral branch will give sensory supply to the anterior thigh.
Anterior. Okay. Upper thigh. Okay.
Yeah, upper
So
thigh.
then we have third. We discussed third nerve, our obturator, right?
The lateral femoral cutaneous
Yes.
nerve.
Lateral femoral cutaneous. Yes.
Yeah. So lateral femoral cutaneous nerve, it will supply like the lateral portion of the thigh, as the name is
Yes.
suggesting, and it can be compressed by obesity and tight clothing.
Okay.
So it's a pure sensory nerve.
Okay. Perfect.
And
Your
this
obturator.
obturator nerve, they are supplying the adductor muscles of the thigh, motor supply to the adductors, and the sensory supply is to the medial portion of the thigh, little bit like near the pelvic area. So during the pelvic surgeries, it can get injured.
Okay, perfect. So now let's discuss our another nerve that is basically your femoral nerve. So here you guys can see this is your femoral nerve, and you have L4, L2 to L4. Here you can see L2, L3, and L4 contributing in formation of this nerve. Okay, as the name indicates, it's femoral nerve. So it's going to supply. Yes, you can like simply
Quadriceps
write the name.
femoris.
Yes, like femoral. So it's going to supply the anterior thigh muscles, right? Okay, and along with that, it's like present in the femoral area. It's also going to supply your hip flexors, hip flexors. And again, okay, this is the motor supply and the sensory supply. Again, the anterior and medial aspect of your femur, simply as the name indicates. Okay, so okay, what are some hip flexors? Flexors. Let's discuss here. Okay, we have a good anatomy of these hip flexors here. Okay, so basically you have three hip flexors. Here you can see the iliacus joining with the psoas muscle, right? It's going to be inserted here. So whenever I am contracting this muscle, so it's going to flex your hip, right?
Mm-hmm.
So the iliacus muscle, it's going to flex your hip.
Hip.
Okay, second muscle here you guys can see the pectineus muscle, right? So whenever I am just like pulling off this pectineus muscle, so it would also help in flexion of your hip, right? And then you have a long muscle that is this sartorius muscle. Okay, it has been inserted here. For example, if I'm flexing it, if I'm pulling this muscle from this part, again it's going to flex your hip. So these three flexors of your hip are basically supplied by your femoral nerve, right? Okay,
Mm-hmm.
so femoral nerve also supplies your anterior thigh muscles, as we already discussed. So anterior thigh muscles are going to, yes, it's going to extend your knee, or it's going to, yes. For example, if I'm pulling these muscles right from here, so what does it do to your knee?
Extend.
Extend.
Yes, so these muscles, these groups of muscles are going to extend your knee. Okay, we have a reflex that is known as patellar reflex, right? If you guys remember. So if you are striking the patellar tendon, so your knees kick up.
Hmm.
Okay, why does your knee kick up? Basically, we are stimulating these quadriceps muscles, the four
Hmm.
muscles which are present in the anterior thigh, right? So it means that anterior thigh muscles are going to extend
Extend your
your knee,
knee.
right? And what are, okay, they are known as quadricep. It means you have four muscles present here. What are the name of those muscles? Here you guys can see you have your rectus femoris, this muscle, your rectus femoris. Then you have your vastus muscle. That is vastus lateralis intermediate, just below this rectus femoris and your.
Dr. Ahmed, we cannot hear you.
Hello, hello.
Yeah, we can hear you now.
Okay, we have rectus femoris, this muscle. Then we have three vastus muscles. Vastus lateralis to the lateral side, vastus medialis to the medial sides, and just below this rectus femoris, we have a muscle that is known as vastus intermedialis, like in between, right? So all of these muscles are basically supplied by your femoral nerve. And
Femoris.
another thing which we have already discussed, femoral nerve, okay, is also going to supply your anterior. Okay, this was your lateral femoral nerve, femoral
Footing.
cutaneous nerve, right?
Hmm.
Okay, so here, okay, we have a small area here which is supplied by your obturator, right?
Obturator.
Okay, and most of the anterior thigh as well as the medial thigh, it is basically supplied by, you have sensory
Femoral.
innervation from your femoral nerve, right?
Right.
Okay, so femoral nerve is also going to give a branch that is basically known as saphenous nerve here, right? So this saphenous nerve is basically going to supply the skin of medial leg and foot here, your medial leg and your foot. This is also branch of your femoral nerve, which is giving sensory innervation to your medial um, side of your leg and foot. So all of these, okay, these are what the function of femoral nerve, right? So as we have already discussed, for example, we have a reflex that is known as patellar reflex, right? All of the reflexes lies inside your spinal cord, right?
Yeah.
Like the pathway, it's going to go into the spinal cord, and then you have reflex coming from the spinal cord. So you have an afferent and efferent fibers, right? So basically this femoral nerve participates in the patellar reflex, right?
Mm-hmm.
Okay. Another thing, we have a term that is known as femoral nerve block. For example, if we have certain, let's suppose if you are undergoing certain surgical procedures in the thigh. So in order to give anesthesia, so we are going to block this femoral nerve because it's going to supply the most of anterior bulk of your thigh, right? So how to check? You also have a UWorld MCQs. If you guys remember in cardiology, we discussed that. If you are for example, here in the femoral artery, we are going to insert the catheter in order to lick your heart structures. If you guys remember, right? So if you are just placing the catheter above the inguinal ligament, so you have increased chances of retroperitoneal hemorrhage. Remember those that MCQ?
Mm-hmm.
Right. So how to look for the femoral nerve? There was anatomy present. You have to have a mnemonic that is
Naval
NAVL. Yes, you have a nerve, you have an artery, you have a vein, and then lymph nodes from lateral to
to
medial.
medium.
So it's very easy to palpate the artery, right? And just to the lateral side, just give them anesthesia there in order to block your femoral nerve, right?
Mm-hmm.
Okay, is that clear?
Yes.
Yes.
Okay, so here you guys can see this is your nerve, your artery, your vein, and some lymph nodes here. So lateral to the artery, the palpation of your artery, you can just block off this nerve. Okay, so now we'll be discussing another nerve that is sciatic nerve. Okay, so first of all, let me just mark it here. Your sciatic nerve, you know, it's your biggest nerve, right? And sciatic nerve is basically damage. If you guys remember, you have an MCQs in your word. For example, if I have posterior displacement of my femur bone, so it's going to damage which nerve? Hello? Posterior displacement of your femur bone. This posterior
Sciatic nerve.
sciatic nerve. Yes, it's going to damage your sciatic nerve. So it's the largest nerve in your body. Here you guys can see this is your sciatic nerve. Okay, so here in the sacral plexus, you can see the sciatic nerve coming, and it have innervation from L4 to S3. Okay, this is your L4 till your S3. They are going to contribute in the formation of sciatic nerve. So it's the largest nerve inside your body. So in okay, near the fibula, basically, okay, what's the idea? Let me just come here. So okay, so near the fibula, nerve, okay, is going to be divided into two branches. Okay, can you guys tell me what are those two branches?
Common peroneal.
And
Okay,
tibial.
common peroneal, also known as fibular nerve, right? And then
Yeah.
you have your
Tibial.
tibial nerve,
Tibial.
right? Okay, the common peroneal is further divided into two. Yes.
Superficial and deep.
Okay, superficial and deep. Okay, superficial is going to supply the lateral side of your leg, the lateral compartment of your leg. And what's the function of your lateral compartment? You can think of it's going to evert your foot, right? What's eversion? Okay, let's give me a second. Here I have a picture of eversion. Okay, so like this is eversion. Like if you are lifting off your leg like that, and this is inversion, right? So it's simple. For example, this is your lateral portion. If I am pulling off these muscles, so what happens? Like from here, it would evert your foot, right?
Yeah.
Okay, so it means that superficial branch is going to supply the lateral muscles of your leg, and if I am pulling these lateral muscles, what happens? It's going to evert your foot, right? Okay, then I have a deep fibular nerve. It's going to supply the anterior portion of your leg muscles. If I am pulling these muscles, it means it's going to, yes, dorsiflex your. If I am pulling these muscles from here, right? So it's going to dorsiflex your. This is dorsiflexion and this is plantar flexion. So it's going to pull your leg upward. This movement is basically known as dorsiflexion, and it's going to extend your toes, right?
Yes.
Hello, let me repeat it again. Here,
Yes.
okay, okay, just give me a second. So here, basically, your sciatic nerve is divided into two branches: your common peroneal and your tibial, branch, right? So the common peroneal is further divided into two branches: your superficial fibular and your deep fibular. The superficial fibular is going to supply the lateral parts of your leg. It's going to supply the lateral skin as well, lateral. And if I am supplying the lateral muscles of my leg, it's going to evert, it's going to lift your foot like in this way. Okay, for example, if it's your lateral side, I'm just pulling these muscles. So you're going to see foot movement like that. Okay, you will lift this part of your foot from the ground. It's known as eversion, right?
Mm-hmm.
Okay. Then you have superficial and deep. Deep is going to supply the anterior compartment. So if you have muscles in the anterior compartment, right, like that, and it's just inserting into your leg. If I am pulling them, it means it's going to lift up your leg. That is your foot. That is dorsiflexion, right?
Right.
Yes. Okay. So you have your superficial fibular nerve, okay, common. Let me repeat it again, just quick review. Okay, you have common fibular nerves, you have motor and sensory. Okay, along with the lateral side, it's also going to supply the lateral skin and the anterior skin as well, right? So you have your superficial, it's going to supply the lateral leg and it's going to evert your foot. You have the deep fibular, which is going to supply the anterior compartment muscles of your leg and it's going to dorsiflex your. Yes, it's going to dorsiflex your
Foot.
foot. Okay, so common peroneal nerve. Okay, so if we have, for example, fracture to this part, the fibular part, right? So we can easily damage the common peroneal nerve, right?
Mm-hmm.
Okay, how can it be damaged? For example, if we have a direct fracture, or for example, if someone is comatose or he's in like bedridden and he's lying on this side and he does not know and he just compresses upon this nerve. So in that case, this nerve can also be affected, right? So for example, if I am losing this common fibular nerve, or simply think of, I am losing this ability to dorsiflex, right? If I am losing this ability to dorsiflex, what happened? My foot would
Foot drop.
drop down, right?
Mm-hmm.
The opposite muscles, which we'll be discussing in the tibial section, which is going to plantar flex, those muscles are going to dominate simply, and it's going to drop down your foot, right? So we are going to see foot drop whenever you have injury to your common peroneal common fibular nerve, right? Okay, and you are going to see sensory loss. Okay, it's also going to supply the sensory on anterior as well as dorsum of the foot, right? So you are going to see sensory loss on the dorsum and lateral shin, like this part and this part, right? You are going to see sensory loss in these parts. Okay, so we have discussed this branch, the common peroneal, which further have two branch. Then we have the tibial remaining, right? So tibial branch basically come like here. You guys can see on the posterior aspect. This is your tibial branch, right? So as the course of this nerve indicates, it's going to supply the posterior. Okay, we are done with the anterior, with the lateral. We are left with the posterior compartment muscles, right?
Mm-hmm.
So it's going to supply the posterior compartment of your leg muscles. Don't just remember their name. For example, if I am pulling these muscles, so which action am I going to do? Which
Plantar
action?
flexion.
Plantar
Yes,
flexion.
I'm going to plantar flex my leg, my
Mm.
foot, right? Okay. And along with that, it's also going to supply the sensory innervation from the heel towards the sole, right?
Mm-hmm.
So, for example, if we have lesions to the tibial nerve, so what happens? Yes, you're going to see, yes, the posterior leg muscles are going to become weakened,
Mm-hmm.
and you're going to see sensory loss on the heel and sole, right?
Right.
Okay, they are also going to undergo another function as well, the inversion.
Mm.
Inversion is basically done by these muscles here. Okay, the posterior compartment muscles. Okay, this nerve basically passes through the medial malleolus. So in this way, you can just remember, if I'm pulling these medial side muscles, so my foot is going to invert, right? It's
Mm-hmm.
going to, okay. So how does this tibial nerve get damaged? Okay, it can damage it two sides. For example, it can be damaged somewhere here, and it can also be damaged somewhere here, which is known as, you have a tarsal tunnel, right?
Mm.
That is a tunnel in which this tibial nerve is going to go inside your heel and supply your dorsum of the foot. For example, if we have lesion somewhere here, it means that the muscles are going to be spared. You have no problem with the muscles. But if you have lesions in the okay, so muscles are spared, but if we have lesions somewhere here in the popliteus, as one condition we have discussed, the Baker cyst, that big cyst develop in the
Mm.
popliteal fossa. So what happens in this condition, you are going to see both weakening of your posterior compartment muscles as well as sensory loss in the, yes,
Good.
sole.
So,
Okay. Okay, so we are going to see laws of plantar flexion, laws of toe flexion, as well as laws of inversion. Okay, so another nerve which we'll be discussing is your pudendal nerve. Okay, let's come here to the plexus first. Okay, so you have a pudendal nerve here. So pudendal nerve basically comes from S2 and S4. Here you can see, right? So basically it comes from S2 like that and S4. Okay, so the pudendal nerve is going to supply, yes, your genital area, right? Like what comes in your genital area, for example, it's going to supply the muscles of perineum, right? It's going to all, it's also going, if you guys remember, we have already discussed, for example, if a woman have multiple deliveries, so we can have damage of in the renal section, if you guys remember. So we can have damage to the pudendal nerve. So we are going to see weakening of levator ani muscles. Remember, levator ani muscles helps in the urethra just against your uterus. So you are going to see incontinence, that is known as stress incontinence. Remember, and what are the treatment options for that? These are your UL MCQs. Kegel exercises. Remember?
mhm.
So this is the pudendal nerve which we have already discussed. So it means it's going to supply the muscles of perineum. It's going to supply the muscles of the levator ani muscles, right? Levator ani muscles are basically going to give strength to your external urethra, right? So and it is also going to supply your external urethral sphincter as well as external anal sphincter, right? So if you have any damage to the pudendal nerve, okay, in female, what's the most common cause of pudendal nerve injury?
Normal vaginal delivery.
Yes, normal multiple vaginal delivery. Okay, so it can cause pudendal nerve injury. So we are done with the lumbosacral plexus. We are almost done. So anyone who can just give us an overview. Okay, we have Dr. Renu have given overview till the, okay. So anyone who can just give us an overview from the sciatic nerve, free, okay, femoral nerve. Yes, I'll be helping you guys. Just take an initiative, please.
Okay, I'll go. Femoral nerve, it's both sensory and motor. Motor
Perfect.
supply is to flexors of the hip joint, which are
Yeah.
iliopsoas muscle, pectineus, and sartorius.
And sartorius. Okay, what's the function of these three muscles?
Hip flexors.
Yes, they are hip flexors, and it's also going to supply the anterior compartment muscles, right?
Yeah.
Okay,
Those
what's
are
the function of
quadriceps
anterior
femoris.
compartment muscles?
Quadriceps femoris, which consists of rectus
Yes,
femoris, vastus medialis, vastus intermedius, and vastus lateralis.
lateralis. Yes.
These muscles help causes extension of the knee.
Simply, you can think of their causes your patellar reflex. So, in patellar reflex, basically, you are extending out your knee,
Okay.
right? Okay.
Yeah.
So, it also have, yes, perfect. So,
Sense.
femoral also have another branch that supplies the medial. Yes, what's the name of that?
Saphenous nerve.
Saphenous nerve. Perfect. Okay, this saphenous nerve can be damaged. For example, you guys know that in, okay, we have already discussed that in the cardio section that basically we take saphenous vein for cabbage, right?
Yes.
Okay, so it can be damaged. Like for example, if you are taking out the saphenous vein, so it is in close proximity to the saphenous nerve. So in that situation, we can damage the saphenous nerve. If you damage the saphenous nerve, it means we will be losing the sensory innervation towards the medial side of your leg. Okay.
Okay. Okay.
Okay, perfect. So can you just tell me the sensory branches of femoral nerve?
Uh, Sensory supply of the femoral nerve is to the anterior and medial part of the thigh,
Okay,
and its
perfect.
branch saphenous nerve innervates the medial aspect of the leg.
Perfect. So, for example, if we are if we have if you are undergoing some a surgical procedure in the thigh and we are blocking off this nerve, so how to check the exact location of this nerve, like in proximity to artery, lateral to artery? Can you just tell us that? What's the
Uh,
anatomy of this nerve in
yeah.
relation
It's
with the
L,
other?
A, V, and L from lateral to medial.
Yes.
Laterally, there is a nerve followed by artery, followed by vein and lymph nodes.
Perfect. Okay. Then we have our sciatic nerve. So can you just tell me what are the two branches of sciatic nerve and what are the function of those uh,
Yeah.
nerve?
Sciatic nerve is the largest nerve in the whole body. It runs
Okay.
posteriorly.
How does the sciatic nerve get damaged? One of your U world MCQ. Whenever you have posterior dislocation of your femur bone, right?
Yeah.
Whenever we have posterior dislocation like here, for example, if I have a hip fracture and this bone is just moving posteriorly, so it's most likely this dislocation is going to damage your sciatic nerve, right?
Yes.
Okay, this is one of your reward lamps. Yes, you can proceed further.
Sciatic nerve branches into common peroneal nerve and tibial nerve.
Okay.
And the common peroneal nerve further divides into superficial peroneal nerve and deep peroneal
And
nerve.
deep, yes.
Superficial peroneal nerve innervates the sensory over the lateral aspect of the leg, along with
Yes.
the supply of muscles to the lateral aspect of the leg. It
Perfect. And what's
causes
the function of these muscles?
eversion.
Eversion. Perfect. Okay, what's the
And
function of the deep branch of the common peroneal?
deep peroneal nerve supplies motor supply to the anterior aspect of the leg, which causes dorsiflexion
Yes,
and
it
extension
causes.
of the toes.
Yes, and it's also have sensory innervation to the dorsum of your foot.
Foot. Sorry.
Okay.
Yeah. And the
Then
tibial nerve supplies to the posterior aspect of the leg. It causes plantar flexion along with the flexion of the toes and sensory to the sole of the foot, heel and
yes,
sole.
heel and sole. Okay, we have two locations in which this tibial nerve can be damaged. One in downside in the yes, tarsal tunnel and other upward in the popliteus. So if you have a lesion in the popliteus area, for example, due to a cyst, that is your Becker cyst. So you can have manifestation of both losing your muscle innervations as well as sensory innervation to the sole. But if we have damage in the tarsal tunnel down, so the muscles, the motor innervation to the muscles are going to be spared. You are going to see sparing of these, right? But whenever you have damage there, you will be seeing sensory loss in the heels and soles, right?
Yes.
Okay. So, okay. Okay. So let's discuss radiculopathy. Okay. Do you guys know what is radiculopathy?
Compression of radicals of nerves.
Okay, perfect. If we have compression of nerve root in the spine level, so we are going to see radiculopathy, right? So there can be certain causes of compression of the nerve root. As you guys know, for example, okay, these are your vertebrae, right? Vertebral bodies. Okay, so here basically runs a ligament that is known as anterior longitudinal ligament, and you have posterior longitudinal ligament, right? And in between you have pads, okay, that are basically known as discs, right? Disc present between the vertebral bodies, right? And here posteriorly you have the processes, the facets, right, which joins one another. And here you have like a canal which is made by them, right? And you have a ligament here which is known as ligamentum flavum, right? And like these are the spinous processes, Okay, so basically your nerves come out here in these spinal columns, right? Hello.
Yes.
Okay, so these are your disc. For example, okay, let's discuss the anatomy of disc. So inside the your disc, you have a nucleus pulposus, and you have a fibrous ligament that is known as annular ligament. So very high yield. Can you guys tell me that nucleus pulposus is remnant of? Yes, it's remnant of notochord. It's very high yield. You are going to see in MCQs. Okay. Do you guys know what is notochord? For example, whenever your neural plate is formed embryologically, so you have three layers: the ectoderm, the mesoderm, and the endoderm. Mesoderm is going to form the notochord. Is going to send signal to the ectoderm, and ectoderm is going to become thickened, and ultimately it would result in formation of neural tube. First of all, neural plate, and then it would wind off in order to form a tube, that is neural tube. So this is the notochord, and this is nucleus pulposus that is present inside your disc. Is the remnant of your notochord. So the posterior longitudinal ligament is weak, right? So sometimes what happens, for example, if we have, for example, if someone is lifting weights, right? So he can have damage to these vertebral disc. So what happens, the nucleus pulposus can just rupture this annular fibrosis, and it can just leak out like that, just penetrating through this posterior longitudinal ligament, and here it can comes out and can compress the nerve. Whenever we are compressing the nerve, so it's basically radiculopathy, right?
Yes.
Okay, secondly, what happens, for example, with aging, your disc just have like wear and tear, so they can degenerate with time, right? So if they degenerate, so the space between them can, like between these vertebral bodies, can become less, right? So as a result of that, what happens, you can have this space, that is the spinal columns, also becoming thin or stenosed, right? So they can also compress upon these nerves, giving you radiculopathy, right? And you have a ligament present in between these structures, which we have already discussed, that is ligamentum flavum. What if this ligamentum flavum becomes hypertrophy? So it can also compress upon this nerve, giving you radiculopathy, right? Hello.
Yes.
Okay.
Yes.
So, for example, if someone, like, for example, we have an aged person, and he have this disc, like he have wear and tear in this disc, and as a result of that, what happens that his spinal column become thin, and you are compressing upon these nerves. So this is basically your narrowing of the spinal canal, can also result into, yes, compression of your spinal cord, right? And it can give you spinal, that is narrowing of the spinal canal and spinal stenosis, right?
Mm-hmm.
Okay. Okay. What's specific about spinal stenosis? How to look for spinal stenosis? For example, okay, remember whenever we have extension of this vertebra, so it's going to, like this foramen is going to become like thin, right? Or stenosed. Or, and if we are flexing our vertebra, so what happens, you have more space for this nerve. Simply you can imagine of this foramen just become enlarged, right? So in spinal stenosis, what would be the main complaint the person will be like telling his physician, that whenever I just flexed my, yes, flex my vertebral column, so I have relief of the pain, because it's going to give you like like extreme pain, right? If I'm compressing upon the spinal nerve, and whenever I stand up, or I'm just extending the,
Hmm.
yes, if I'm extending the vertebral column or this vertebral bodies, so what happens, I'm further stenosing, I'm further decreasing the space of this spinal column. So I will be further impinging upon this spinal nerve, right? So this is the classical history which a patient is going to give you, right? So if you have this nerve being compressed, so it's going to give you some pain. Okay, that is basically known as neurogenic claudication. Like for example, if we have we can also have claudication due to whenever your vascular supply is diminished to certain organ, and if you are like running, and if you are using that muscle, so it's going to give you pain, right? And that is basically ischemic pain, and that can also be termed as claudication. You are going to see claudication. But what's specific about Neurogenic claudication, the person would be saying whenever I flex, okay, I bend forward, so the pain improves. Or whenever I'm standing, even at rest, I have more pain, right? And it isn't like getting worse whenever I'm having activity. When I'm standing at rest, still I'll be having pain, because at rest, if I'm standing, still I'm extending my vertebral bodies and like compressing upon these nerves, right? Okay, so can you guys tell me what's radiculopathy and how we are going to see what's herniation, how can it cause radiculopathy, spinal stenosis? Yes, anyone?
Okay, so radiculopathy is like when the nerve roots are getting compressed at the spine.
Yes.
So that is what is radiculopathy is, and it can occur because of many different causes. So, like in this intervertebral disc, we have this pad here, which is like the inside soft portion is the the nucleus pulposus, and
Yes.
outside we have the annular fibrosis.
Yes.
So, when the nucleus pulposus, like when the annulus fibrosis ruptures, the nucleus pulposus just comes out and it impinges on the nerve roots.
Yes.
So, one reason is that, and second reason could be um, mm, that posterior ligament is torn or injured because the
Yes.
posterior
Because it's weak as
ligament,
compared to that
it's
of
the
anterior
anterior
lung.
ligament. Yes, the posterior ligament is weaker than the anterior ligament. So if that is injured, in that case also we can have this radiculopathy.
Yes. And what
Then
if the ligamentum flavum gets okay with age, wear and tear, and ligamentum flavum hypertrophy? These can also impinge upon that spinal nerves, right?
yes, yes.
Mainly in the lumbar area. Why? Because they are more prone to weight. If we are carrying weight, so more of the force is going to be
Hmm.
transmitted via the spinal vertebra into your lower legs, right? So the
Yes.
lumbar region is prone to have rupture of these discs,
Mm-hmm.
hypertrophy of the ligamentum flavum.
Hmm.
Yes.
So the foramen actually narrows down. So
Okay.
on extension, like when the person is standing up, he will have more pain, and when he is flexing or bending forward, then the pain is relieved.
Okay. Perfect. So this was all about radiculopathy. Now let's discuss sciatic nerve. We have already discussed the sciatic nerve, but whenever you have branches in the knee, let's discuss it a little bit upward. What happens, what happens upward? So you know that sciatic nerve basically comes here. Okay, just let me show you this picture. Okay, here you guys can see. Okay, the pictures. Okay, so this is basically your nucleus pulposus, your annular disc, right? So it can just herniate and it can impinge upon this nerve, right? These are the pictures you can see. This is your anterior longitudinal, posterior longitudinal, your ligamentum flavum, and here the nerves come out, right? So you can have herniation, you can have hypertrophy of this ligamentum flavum as well. So here, whenever you have, okay, these facets are going to rub against one another with aging, right? And it's going to form bone spurs, that osteophytes, which we'll be discussing in the pathology section, right? So here, okay, now let's discuss sciatic nerve. So you know sciatic nerve is the largest nerve, okay, and it comes out from your, yes, like here, the L5, okay, the S5, the lumbar, the sacral, all of them contribute in the formation of sciatic nerve. And okay, in which kind of dislocation we are going to see damage of sciatic nerve? Posterior dislocation, right? So here the sciatic nerve is going to supply your posterior thigh muscles here, and in the posterior thigh muscles you have a group of muscles which are basically known as your hamstring muscles, right? Hello.
Yes, yes.
So it means they are going to supply your hamstring muscles. Okay, so you have The hamstring muscles simply you can remember if you have three posterior thigh muscles, the membranous, name membranous coming then. That is semimembranosus, right? Your semitendinosus and bicep femoris. Okay, let me just show you here. Okay, okay, so it's going hamstring muscles. So, okay, you have adductor longus, which we discussed that some of the parts of adductor longus are going to supplied by the obturator, right? So adductor magnus also have a hamstring portion. Hamstring portion. Okay, what's for example, if I have muscles in the posterior thigh, or what would be its function? You can simply remember if I am pulling them and from their from this side, it means it would be extending your hip, right?
Right.
Okay, for example, if I'm pulling it them, right, so it's going to extend your hip in this direction. And what's the effect on the leg? It's going to flex your leg. You can simply think of the insertion is here. If I'm pulling them from this side, it's going to flex your leg, right? So what's the function of these hamstring muscles? They are going to extend your leg and it's going to flex. Okay, they're going to extend your hip and it's going to flex your leg. Okay, you have three posterior thigh muscles, membranosus, just remember it. Semimembranosus, semitendinosus, and bicep femoris. And adductor longus, it have a portion that act as a hamstring muscles. So all of these three are going to be supplied by your sciatic nerve, right? Hello.
Yes.
Yes.
Okay, so if we have, okay, this is your fifth number, right, and your fourth number. So as we already discussed that the radiculopathy can occur in the lumbar region, right? So it can also compress upon the fourth, the fifth, right? The fourth and fifth portion, which contributes in the formation of sciatic nerve, right? So you can have certain outcomes of the sciatic nerve being involved, and we know what's the function of sciatic nerve now, right? So you have then their branch common peroneal, that was the branch of sciatic nerve, already we discussed, right? So for example, if we have impingement of these nerve roots, so it means you are going to see a condition that is known as sciatica. So what sciatica? You are going to see pain along the course of sciatic nerve. What's the course of sciatic nerve? You will be seeing pain in the lower back, okay, following the buttocks and at the back of thigh. Here you will be seeing, you'll be experiencing a pain. Those who have sciatica. Okay, what can be some reasons? Okay, for example, if we have radiculopathy somewhere here and it's impinging upon these nerves, so it means not all of the sciatic nerve is involved. Like you know, sciatic nerves have branches from all of them, right? So you're going to see some outcomes, not complete outcomes of sciatic nerve. That is the posterior compartment muscle motor loss. Like some of the function of sciatic nerve is going to be disrupted. But if you have lesion somewhere here to the complete sciatic nerve, then we will be seeing that your posterior compartment leg muscles won't function well. Similarly, your lateral compartment that is basically supplied by the superficial peroneal, the anterior and tibial part, right? Okay, so the most common radiculopathy which happens is the involvement of your fifth lumbar, right? Okay, what can be some of the causes of sciatic nerve neuropathy? For example, if someone already discussed, if someone have fracture and your femur just moves or dislocate posteriorly, so you can have damage to your sciatic nerve, right? Similarly, hip replacement surgeries and prolonged compression of this nerve can also cause sciatic neuropathy, right? Okay, so the nerve root, as we have discussed, L5 is the most common. Okay, what can be some of the reasons of this impingement of this L5 portion of the sciatic nerve? For example, again, herniated disc at L4. L4 is going to herniate, and as a result of that, it's going to impinge your fifth lumbar, right? Okay, remember whenever you have the fifth lumbar involvement, which function of the sciatic nerve is going to be impaired? That is foot dorsiflexion. And okay, foot dorsiflexion was carried by, if you guys remember, deep branch of the
Deep
common
peroneal.
peroneal, right? Deep branch of the common peroneal. So it means whenever you have L5 lesion or L5 radiculopathy, you are going to see deep
branch of common peroneal nerve impairment, right? That is, you will be seeing weak dorsiflexion. If you have weak dorsiflexion, so it can lead to foot drop, right?
Would drop. Mm-hmm.
Okay. So we can also have radiculopathy at S1 nerve root as well here. But whenever we have S1 nerve root involved, so simply imagine of you are going to see the outcomes of that tibial portion. Okay, the tibial branch of the sciatic nerve. So it means we will be having difficulties in plantar flexions, right? Tibial component. If I am pulling it, it was plantar flexing your
Yes.
um, yeah. So you'll be seeing, okay, and again you are going to see laws of the ankle reflex. What's the ankle reflex? Just hit your ankle here, the tendon. So your foot is going to plantar flex, and plantar flexion is basically carried by your tibial branch, right?
Mm.
So the idea is whenever, okay, S4, okay, tibial, okay, ST, okay, just simply remember of the ST segment, right? So So how to okay? What's the bedside menu in order to see, for example, if someone have lumbar radiculopathy? Okay, just tell them to like lie in a supine position, raise his legs till 90 degree. So it means you are compressing upon the nerves inside your lumbar region. So you will be seeing, yes, if someone have radiculopathy, you will be seeing worsening pain, right? So leg rest test is basically used in order to check the pain due to radiculopathy. So anyone who can just give us an overview of this nerve which we discussed? Yes, the sciatic nerve. Hello. Yes, please.
So, the sciatic nerve is the largest nerve, and it's like motor supply to the posterior compartment of the thigh, the posterior thigh,
Okay.
which is like our hamstring
Hamstring.
muscles. Yeah,
Yes.
yes, hamstring muscles, and it those are like the membranosus muscles, semimembranosus, semitendinosus, and biceps femoris.
Biceps. Perfect.
And the function is they will extend the hip and flex the knee.
Okay, they will extend the hip and flex the knee. Yes.
Yes, hip extension, knee flexion. Yes. So then what else was there?
Okay, it's going to supply the hamstring portion of the magnus, big magnus
Adductor
muscle,
magnus. Yes.
adductor magnus. Yes.
Yes. Mm,
Yes. So you can have in, okay, sciatic nerve is formed from from many lumbar branches, that is L4, L5, first sacral. So for example, if someone is having that herniated disc, so it can impinge upon the fifth lumbar, and fifth lumbar is the most common
fifth,
if you have involvement of the fifth lumbar. So we are going to see loss of the anterior compartment, that is the deep branch of common
common
um,
peroneal nerve.
peroneal, which just undergo the dorsiflexion.
Hmm.
So we'll
So
be
there will
seeing
be
foot drop.
foot drop. Yes.
Yes. If we have involvement of the first sacral, so the tibial portion of your sciatic nerve is
Tibial
going to
nerve is
be,
gone. Yes. So there
yes.
will be like a weak plantar flexion.
Yes, there would be weak plantar flexion.
Hmm.
Okay. So, okay, here we discussed. Okay, now let's discuss the hip joint. So, hip joint, you have the acetabulum in which your bone is going to be inserted. So it's a ball and socket joint. So you can have various motion. That is abduction, adduction, right? Rotation at this joint, flexion, extension, right? So it's a kind of freely mobile kind of, you know, joint.
Hmm.
Okay. So now let's discuss some of the major flexors of your hip. So what are the flexors of your hip? We already discussed. Yes, flexor of your hip, which are going to be supplied by the femoral nerve.
Iliopsoas,
Okay, iliopsoas, perfect.
pectineus,
Pectineus, yes. What about
sar-
sartorius?
sartorius. Yes, sartorius.
Perfect. Okay, what are some of the common extensor of your hip? Already discussed.
Oh yeah, the semi-membranous
Hamstring.
Tendinosus and
Perfect.
yeah, biceps femoris.
Yes, biceps femoris, semimembranosus, semitendinosus, that are your hamstring muscle,
Hmm.
right? And gluteus maximus as well. Okay, what's the gluteus maximus? That big muscle here. This is your gluteus maximus, right?
Hmm. Hmm.
It's also going to extend your
Extend the hip.
hip.
Hmm.
Okay, what are the common abductor? We know the adductor by the obturator nerve,
Hmm.
the adductor
Abductors are
brevis,
medius,
longest, magnus. Okay, what are the abductor?
medius and
I
minimus.
Perfect. That is your gluteus medius and
Minimus.
gluteus minimus. So here, okay, here you can see these are your gluteus medius. That is like inserting on the upper trochanter. This is your upper trochanter, right? And your gluteus medius here. Here you can see your gluteus medius. So they are going to abduct. So
Hmm.
this is the abduction, like this exercise. If ever you have been to gym and you just perform this exercise. So this is basically abduction of your hip,
Hmm.
right? So for example, if we have damage to the upper trochanter here, so it's going to you are going to see losing of your abduction, right? So it is also one of your UWorld MCQ, right?
Hmm. Hmm.
So okay, what's the nervous supply of the gluteus medius and minimus?
Superior gluteum.
Superior gluteal nerve.
Superior gluteal. Yes, you are going to see an MCQs on it. Like here you can see, okay. So basically superior gluteal runs somewhere here, right? So it's the best part, the lateral, the upper lateral portion is best site for intramuscular
Hmm.
injections, right?
Hmm.
If you just did it like a little bit medial, so you are going to see damage of superior gluteal, that is supplying your gluteus
Medius.
medius and minimus. So
Minimus.
you will be having loss of abduction, right?
Hmm.
This is one of your UWorld MCQ. So avoid to just do the IM injection in the medial side. So for example, if someone have loss of these gluteus medius and minimus, so you'll be seeing a sign that is known as Trendelenburg sign, right? What is Trendelenburg sign? For example, if this lady is running, it means hip, her like this pelvis is okay, not changing its direction. So in Trendelenburg sign, you'll be seeing tilting of this pelvis, right? Because
Hmm.
you have weak abductor due to that superior gluteal nerve involvement on the affected side.
Hmm.
Okay, so here you can see this is one of another MCQ. This head of the femur bone is going to be supplied by your, yes, medial circumflex, right?
Yes.
Okay, whenever you have disruption of your medial circumflex artery, you are going to see head injury to the femur, right?
Hmm.
Here you guys can see. Okay. Okay, so we have a condition that is basically known as avascular necrosis. Anyone who can just tell us what's avascular necrosis?
Due to compression and decreased blood supply.
Okay, due to decreased blood supply, you can have necrosis of your bone. So there are
Femoral
certain
vein.
reasons.
Hmm.
For example, if someone have trauma, so it can disturb the vascular supply, and you can see necrosis of your bone. There are also some causes which do not involve fractures. For example, if someone is using glucocorticoids, so you can also have avascular necrosis to the head of the femur mainly, right?
Hmm.
On steroid therapy. For example, if someone is having SLE, you are going to see an MCQs in your world related to SLE. For if a person is having SLE, they are going to say with the MRI, he is going to have avascular necrosis to the head of femur, and
Femur.
they'll be asking you why is that so. So it's due to systemic lupus erythematosus because there are two reasons. In SLE, normally you are going to see necrosis, and in SLE, you are also using the steroids, right, in order to suppress your immunity. We have already discussed glucocorticoids, right, the treatment option of for SLE. Similarly, for example, if someone is having sickle cell anemia, we have already discussed, you are going to see sickling of the red blood cells in the small vessels, which is going to give you dactylitis, that is bone pain. And ultimately, the blood supply to the bones are going to be disrupted. And as a result of that, you will be seeing you will be seeing avascular necrosis, right? So you can have this damage here. Okay. So this was all about the leg, and tomorrow, like the lower limb, and tomorrow we are going to discuss the hand and upper limb, and along with that we'll be discussing pathology, right?
Okay. Okay.
Okay. So thank you guys. Have a nice day. Thank you.
Thank you, Dr.
Bye
Shah.
bye.
Thank you,
Bye
doctor.
bye.
Thank you.
Thank you.